coronavirus implications for perfusion. Now, one of the things that I've been trying to avoid is to have all of this be only the whole perf web series being nothing but coronavirus. But clearly it is a hot topic. It's a big deal right now. There's still a lot that we just don't know and don't understand. So I don't want to overdo it. I don't want it to only be that. Because when I look online, I see nothing but just video after video after video after video being about nothing. Every discussion is about nothing but coronavirus, and certainly it's a big deal. I'm not trivializing it by any stretch of the imagination. But frankly, I think that life is continuing to go on, and I'm hoping that my talk today sheds some casts some light, shines some light on what I think is really a bigger problem than what coronavirus itself ultimately ended up being for most of the country. With all of the data that I've listened to, the number of asymptomatic people that were infected asymptomatic patients is incredible. It's much, much higher, making the mortality rate much, much lower. And also, concerns about how patients or people who were workers that were known to have been infected going into places where there's the high risk category patients, and how that may have exploded the numbers the way it did. I think some of this, and I'll get into it a little more in my presentation, but I think a lot of this was just the unknown, at least that for me, and I'll talk about this on a personal level. Yes, it's a virus, it's a respiratory virus, and it carried with it some pretty serious lung, damage associated with it. But I just am not 100%. I think some of it was just that we just didn't know. We were unsure, and uncertainty and not being sure about something breeds fear. And I think that was part of the problem. There was a lot of fear. Okay, I'm sorry. I don't mean to belabor the point. Let me go on to my slides. So my experience as a perfusion business owner, and that's sort of the direction that I'm going to go with this, is as a practice manager, a business owner, a perfusionist, a clinician as well. How did I manage this? And hopefully it'll be of some value to y'all. So there was a lot of uncertainty when all of this happened. How bad is it really going to get? And I heard all kinds of stories. Some of them scared the hell out of me. I certainly was concerned, even though I wasn't seeing it yet. And I'm in Houston, okay, so keep that in mind. Not New York, I am in Houston. But I was very concerned. I was anticipating, okay, how bad can it get, and how can we plan for that? And as the government started taking more and more steps by stopping, for example, elective surgeries, that was a big step to me. And at that point, we activated our disaster plan. Now, our disaster plan for this happened to be a disaster plan that was created not long prior to that actually happening. So I'm not going to sit here in front of you all and tell you that I had the disaster plan already set up from 10 years ago, anticipating this being an issue. I didn't have this as an issue at the time. But we still put a plan together before the actual shutdown of many of the hospitals, and all of them really with elective cases. And of course, with the understanding or thought that we were going to just be inundated with COVID-19 patients needing ECMO. We did a lot of adjusting as each day went on, and we did a lot of evaluating as each day went on. What happened yesterday? What happened the day? What are the trends? All of that stuff. And we made adjustments to what we were doing based on what was actually happening. I think, when I look back on this retrospectively, what I thought was going to happen actually did happen. But that's, in my view, luck. I don't think I was a fortune teller. I just think that in this particular case, I was lucky and I was right. In fact, when Dr. Samir joins us on this next presentation, on his next talk, he owes me dinner, and I'm going to bring that up. As a matter of fact, in case you're watching, Dr. Samir, I have not forgotten. You still owe me dinner, because Houston really, thus far, and I guess anything could change, but thus far has really been spared from any unmanageable level of COVID-19 patients and infections, and the hospitals being overrun and lacking bed space, ventilators, personnel, the personnel dropping from being infected, all of that kind of stuff. But we have to worry about it, and we were certainly concerned about it. Now I can't see that, so I'm going to have to open it up on my computer. Oh no, I can see it now. Okay, so the things I knew we had to do. We had to provide high level of essential care, because perfusion, whether it be in the case where all the elective cases were shut down and all you're going to see is emergencies, that's when you got to be on top of your game, very, very high, because those are going to be the most difficult of all of the cases. So perfusion is a very essential element for any major hospital to have, especially if it's a level 2 trauma center, level 1 trauma center, certainly, but level 2 trauma center. In fact, it's required to be a level 2 trauma center. You have to have cardiopulmonary bypass capabilities. We had to be concerned about contractual obligations. We had to keep our team members safe and healthy. We were managing different hospital enacted policies. So a lot of these hospitals had policies that they were putting in place as this pandemic was evolving and as it was affecting various different communities. We had to limit the number of team members that were exposed. And the reason for that was because, for example, we had one person who happened to have been out on a cruise before there was a lockdown. Not they went on the cruise despite a lockdown, but it was timing, just bad timing. And ultimately what happened was hospitals then said, if you have been out of the country, in particular on a cruise, you cannot come to that hospital for between 2 weeks and 1 month, depending on the facility. So that took that person out for 2 weeks to 30 days, depending on the facility, hoping, of course, that they didn't contract anything and have problems associated with it, which would have extended that to a much longer period of time. Ultimately, they didn't have anything. Here, let me see those slides. I can't see that screen, so I need to be able to see the slide. Where are we here? I think I'm here. Yes, there we go. Here, I've got it on my computer now, so you won't have as much trouble. We had to, of course, so we limited the number of team members that were being exposed. So if we got a COVID patient, which we did, we said, okay, those people that initiated it, because it required 2 of them, even though they were in full PAPR suits, there was debate whether or not, if they were in PAPR suits, is that actually an exposure? So, that we didn't know. There was no CDC guidance yet at the time. No other facilities were addressing the issue. So the way I viewed it was, we have to err on the side of caution. Those 2 people are going to be the only 2 people that can have any contact with that patient. Now, outside of the room, that was not going to be an issue. It's if they had to go in the room that there would be an issue, even though they would be wearing the N95 mask or full PPE, all that stuff. But they would not be, we would be limiting who would go in, because we, at that time when it first happened, didn't know what a contact definition was. And that created a lot of problems, a lot of anxiety for us. As elective cases plummeted and they were shutting down a lot of surgery centers, which we do with a lot of auto transfusion work in our group as well, the very first thing that I did before I knew about the PPP, the payroll protection program that exists, the very first thing we did was went out to our bank and got a line of credit, a very big line of credit. And that was risky and concerning, but it was the right thing to do. We had to do that. We also, and I'm not saying this to make myself better than anybody else, because everybody has their own reality. They have to live in their own reality, and I don't pretend to speak for everyone or what the right thing to do was. Everybody has a different opinion, and I respect that. But I felt very strongly from day one that we as a group feel that we have highly committed and very professional people that are loyal to this company. Our practice, we have essentially no attrition. And I like everyone that works with us. And I think most days, most everyone likes me too. Not every day, I have my moments apparently, but as we all do. But I felt very strongly that we had to be committed. And so I had made that decision that if I'm going to take this, I'm going to ride this ship to the bottom of the sea. We will not do anything. We're not going to furlough. We're not going to go rolling furloughs. We're not going to reduce compensation. We're not going to force vacations. We're not going to do any of that. In fact, in our disaster plan, it was really quite the opposite, but we're going to discuss that too. But I had to evaluate the financial impact of what this was going to be. I had to interact with administrators of smaller hospitals that may close and did close as to how are we going to manage this transition. We had to find things for the team to do that were productive or that are productive. Some of our team donated blood. Some of our team delivered food for a food bank because they weren't doing cases. We weren't doing emergencies. We had a few. But our caseload essentially went to zero. I mean, it just did. For at least a couple of weeks, we had drib and drab here or there, and then it slowly started to come back, and it's showing signs today, or on Monday's schedule, that we're fine. We actually have scheduled hearts, 3 in one day. We're used to doing 5 to 7, but we're getting there. It's moving in the right direction. I see a light at the end of this very long, dark tunnel. And that's just, I'm an optimist. I try to stay optimistic and see the glass as half full versus half empty. But, again, that's just me. That's my personality. And that's evolved too. I had to follow the news and trends very carefully. I don't think I've ever watched, read, and listened to as much news about one topic ever in my life. And after all of that, being saturated with all kinds of different perspectives and the whole thing changing even intra-day, sometimes several times in a day, as to what is actually happening, it was very frustrating for me as a citizen and as a business owner and as a healthcare professional, all of those things. It was very frustrating at the lack of a concise consistent message. It was all over the map. And I think history will bear that out as having been one of the biggest mistakes that was made. Way too many people had way too many opinions, and none of them were factual, or some of them were, but by luck. And I think that they did a real disservice to all of us by giving out information that just really wasn't useful, and actually made things more frightening than they probably needed to be. You have to keep positive and optimistic, and have that attitude with the, we'll call it my colleagues, but rank and file. If you're a business owner, you have employees. I try not to use that term in that way, but for the sake of this discussion today, I'll say it that way. I truly believe, and have always believed, that your team is a reflection of, or a team is a reflection of the leader. When you have a department that is dysfunctional and angry and mean and backbites each other and is subversive to another team member or other team members, you find that the leader is like that. When the leader is strong, consistent, has a positive attitude, and applauds positive things, good work, hard work, and is just positive and friendly and expects that of themselves, you find the teams will reflect that as well. So you really need to keep a positive attitude, because if I was falling apart, it would be likely they would be falling apart too. Maybe not, but I do think that seems to be the way teams operate. And I think you find that whether it's military service or you find it in sports, you find it in all kinds of things. And I did a lot of praying, and I don't pray a whole heck of a lot, but I did a lot of praying that the decisions we were making were the right decisions at the moment for what we were doing. And and like I said, we were doing several day evaluations, so that anything that looked like it may not have been the right decision, we were making adjustments at that point in time. You have to stay flexible. You have to be able to change on a dime. You can't have to have a committee to decide whether or not you should discuss what's happening, because by the time you get to that point, 3, 4, 5 things have happened, and you're making decisions based on something that's old and historical. You have to be able to change very rapidly and be, very, very malleable. Now I'll go to the next slide. So, special considerations. This is different than a natural disaster. A hurricane, a tornado, earthquake, you can see it. It happens and it's over. This was an infectious disease with essentially an unknown degree of virulence, an unknown degree of transmissibility, how easy, how many, there was more, again, very many unknowns, but it was an infectious disease that's viral. You cannot see it. So you can't see your enemy, and you don't know how long your enemy is going to be hanging around. But all of us in medicine have a special responsibility and an oath. We had this discussion yesterday, and we talked about disasters and how medical professionals deal with that. Do you protect your family, yourself, or do you protect the patients? And look, we have a very special obligation. We need to take care of our patients, and it's troubling and it's concerning. I mean, you shouldn't put yourself. If you have to run through a fire and get and the likelihood is slim or even 50-50 that you're going to make it on the other side of that fire to help somebody, that might not be the right decision, because you have to preserve yourself in order to be able to take care of patients when the fire gets suppressed, and you can get through it or around it or whatever it may be. I understand that philosophy. You have a situation where you have to evacuate your family. Your wife is injured. You have small kids. You have to take care of your family. I understand that too. But notwithstanding your family has the capability of taking care of themselves, just the sense that you want to be there is not enough to say, I don't want to go do this because I might bring something back to my family. Don't come back to your family. You go someplace else. You get a portable trailer. You do whatever you need to do. You find some other mechanism. You isolate yourself to one room of the house. You come and you go. You do what you need to do, because I truly believe that notwithstanding, you can't let yourself be killed, and there's always circumstances that your family needs. You have to be there to protect them. Just not wanting to go because it's I want to be home with my family, kind of that stoic thing. No, you have an oath to take care of patients, and I'm going to tell you something. If it comes to a disaster, like a mass casualty or something like that, we're perfusionists, but we're trained medical personnel. We can do a whole lot more than just turn the knobs on a pump, and we all know that. Again, I'm going to say it one last time. We have a special responsibility to patients that need us. And with exception, we need to take care of those patients. That's my view. It's my opinion. Okay, so I'm going to say that. But we are all human and have families that we love, including ourselves. The team will also be afraid and worried. They will have serious financial fears. So the team, and I was very candid with them. I talked to them, every single one of them. We're getting a loan. I told them what we were doing. I told them that if anything happens, we are all going down together. So did that eliminate their fear of being unemployed or not being able to meet their bills because there had to be a reduction in income or whatever it may be? No, of course not. It didn't completely eliminate it, but it may have reduced it some, and hopefully those messages were heard. I believe they were, and it gave people some sense of relief that we're going to get through this. You always have to have that we are going to get through this. We're bigger than this. We're tougher than this. We're stronger than this. We can do this. We will do this. And I'm going down with you. I'm not going to cut and run and let you sacrifice you for my own benefit. That's a personal decision. I think it's the right decision to make. I think a lot of people did the same thing. I'm not unique. A lot of people did the same thing, and I applaud every single one of them that did that for that decision, because it's not an easy decision. Well, it is an easy decision, but you know it's going to be painful on the back end, okay? The team should be able to look to leadership for direction and encouragement, and with very rare exception, and I say this very sincerely from my heart, with very rare exception, healthcare workers will always rise to the occasion. And I think we've seen that time and time and time again throughout the course of history, and we are seeing it now as well. So I applaud all of my healthcare colleagues who have stepped up to the plate during this pandemic disaster and have conducted themselves in such a highly professional and helpful way to those that are most vulnerable, that need us. You know, the whole thing for us, as far as the impact, came early, and that may have been why Houston was spared the way it was. Simultaneous to our first case, we had a first case, was several hospitals sending notices, I said this already, that anyone traveling out of the country may not enter their facility for between 2 to 3 weeks. What came early was our first COVID patient, so it came really early. We immediately activated our disaster plan, which included immediately canceled all vacations or time off. So everyone was on call until further notice, 7 days a week. There were no exceptions whatsoever as far as that's concerned. Restricted the number of people managing the COVID patients. We addressed that. Separated the group into teams and responsible for one hospital. So we work in several hospitals. So what we did was said, okay, we've got these two that have had, even though by CDC standards later, it was deemed they did not have an exposure because they were in the PAPR suit, but we just considered them as having an exposure. They've had an exposure, they're there. If it's this hospital, it'll be these two people. If it's that hospital, it'll be these two people. So it was, if it got out of hand, it was going to be basically 12-hour shifts, around the clock for as long as it was going to take to manage the situation. We absolutely eliminated any unnecessary travel to hospitals for any reason. So the little things that you have to do when you run a company and you're a private practice organization, you know what? We're not doing them. Put them to the side until this gets settled. I don't want people going out, getting on the roads, having to stop to get fuel, whatever the situation be, go into a hospital for some reason where there's other people. Let's reduce contact as much as possible. So any unnecessary travel that did not involve direct patient care was stopped. We eased restrictions as time went on based on CDC guidance and hospital regulations. And we assessed how many cases could we actually handle. So that's sort of how our disaster plan evolved. Interestingly, for us, we didn't have nearly as much ECMO as I had anticipated. However, ICU beds, ventilators, some important medicines, toilet paper, which I think everybody had that experience, seemed to be in short supply. Miraculously, don't know how that happened. Had ECMO been used more, and it had just like patient after patient after patient I'm referring to, not just used more than we used it, but if it had really been used a lot, it would have been a near impossibility for us. The first thing that would have happened was we wouldn't have enough ECMO platforms. Some hospitals, we provide them. Other hospitals, they provide their own. Nobody had enough. And by the time it got to that point, you could not find them on the market. But you have platforms. I was concerned we were going to run out of oxygenators. How can we use the oxygenator from our pump packs for ECMO? Can we do that? How can we do it? What are the considerations? You know, it has an integrated arterial line filter, which is going to be much more thrombogenic. So how would we adjust that? Yeah, certainly we would do it, but we would adjust our heparin, obviously our anticoagulation of whatever sort we were using in order to accommodate that. But it could be done, clearly. And then I was concerned about trained personnel. If we have ECMO in all of the hospitals and then they start putting more than one in different areas of the hospital, well, there's nobody that's going to have enough people for that. You have state licensure. Even if you took that off, you have other considerations, hospital credentialing. Well, you could eliminate that too. But if it's happening here, it's probably happening elsewhere. There just aren't enough perfusionists. I'm going to address that issue to manage what would be a major increase in the utilization of ECMO on a national level or even a regional level in a couple of regions being hit simultaneously. There just aren't enough of us in the country to do that. Once it became apparent to us that we were not going to be like New York or Lombardy, Italy, By the time it got to that point, elective case volume had gone to essentially nearly non-existent. We recommended that the team donate blood or join the Meals on Wheels. We talked about that. We refined our SOPs. So we actually made really good use of our time. Some of our team became more involved in doing educational programs, which I appreciate tremendously, because I think we all have a responsibility to teach each other. And teaching can be done in a lot of different ways. You know, I think I have a platform, but I also think that I have a standing. You know, I've said this before, and I'm not trying to be braggadocious here. If you just let me, you know, if you don't mind indulging me. But you know, I have 42 years. I'm almost done with my 42nd year. I'll be starting my 43rd year in perfusion come this June 1st as a clinical perfusionist. That's over and above past my training. So I've got a lot of years of doing this and a lot of experience, and I think that experience and my perceptions of things that come from all of that experience is something that should be shared. And I think whether you're like me, an older perfusionist who's been around for a while that wants to teach, please call us up. You know, we really want to hear from you. If you're a younger perfusionist and you're really excited and you're doing some basic research stuff, or you get a really interesting case and you want to talk about that to start learning how to lecture, how to talk to an audience, becoming more comfortable in front of cameras or in front of an audience, please call us. You know, we are very inclusive. I think that I can learn from the youngest perfusionist, and I can learn from the oldest perfusionist. I'm not the oldest. I'm not even the longest in here. In fact, I met a young lady the other day whose dad has been practicing for 46 years, and he's at the infirmary in Mobile. And we've talked. I'm going to talk to him again on Monday, and he wants to join us with some lectures too. And his daughter became a perfusionist as well. So I'm really proud of them, and hopefully she'll join our group. We'd like to have her, but with that said, we'll have to wait and see about that. But we stayed useful. We did things for the company, worked on our new company website that's going to be coming up, worked on this program, developed the Corona 30 programs, which are coming up for helping those people who couldn't get to a meeting or couldn't make it to something or couldn't sit through a full week. We're going to do it over 3 weeks. And we could talk about more about that a little bit later. Let me go on with my slides. But implications for everyone else. And I think this is something that has been lost, has been missed, and something that I am personally very concerned about, okay? So what I want you to look at here is, this is a distribution of inpatient stays with and without operating room procedures by Patient Characteristics 2014. Now, this recognizing 6 years ago, but it takes that long for them to process all of this data. So this was the most current that I could find from the the Agency for Healthcare Research and Quality, AHRQ. But if you look here, the number of stays, all stays for any purpose overnight, 10,115,800. If you were having a non-operating, and that was for an operating room procedure. If you were having surgery, for a non-operating room procedure, it was 25,243,000. If you look down, and that's basically about 40% of patients have surgery that stay in the hospital at least one day or overnight, okay? If you look, you'll see that, just as a point of reference, it looks like females had more than males on both fronts. Very little difference for the operating room procedures, a little bigger for the non-OR procedures without OR. But what's important is the second red box that you see there. look at the age, 65 to 84, our at-risk group, okay, for COVID-19. 26.3% for without OR procedure, 28.2% for surgical procedures. They encompass that. We look here, you'll see that as far as operating room procedures by patient characteristics, it looks like males were 31.6%, females were 26.4%, and the difference there compared to the previous slide was that they may have more procedures, the males, but they're in the hospital a shorter period of time, which I found interesting. 26.4% female, 45 to 64 age group 32.7, 65 to 84 30. So that's essentially 63% of all operating room procedures are done on patients, again, 45 to 84. That is well within our major at-risk age group. 85 plus obviously is too, but you know, but then that was 15.5%, so that was actually a pretty high amount. Take a look here. What are the most frequent all listed operating room procedures? Well, number 4 and 5, hip replacement and PTCA or stents. And then number 10, treatment of a fractured hip. Number 14, CAB, surprising it's that low. 19, heart valve procedures, okay? And if you look at the volume, you can see that we did 201,600 cabbages in 2014, 143,600 heart valve procedures. Now you look here at this slide, and this is the top 5 most frequent all listed operating room procedures by age group. And when you look at age groups 45 to 64, 65 to 84, and 85 plus, you see that number 2, 3, and 4 consistently, or actually 3 and 4, 2, 3, and 4 consistently are going to be PTCA, hip replacement, and spinal fusion or some kind of laminectomy, spine surgery, or whatever it may be. And that goes across all 3 of those age groups. So again, when you look at locking the society down and telling people who are having symptoms not to come to the hospital if they think they're having COVID-19 symptoms, and they're in excruciating pain because they need a hip, is that really the right thing to do? It goes back to uncertainty. It goes back to, you know, we don't know what's going to happen, lack of messaging, and that's probably because the professionals didn't really know what was going to happen. The CDC didn't seem to really know what was going to happen. The government certainly didn't know what was going to happen, and I don't think any of us knew what was going to happen. So I'm not criticizing it, I'm just pointing it out. And then, how many patients stayed at home having angina that thought it was something else because that's all they heard was COVID, 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 and died from an MI? I mean, our cath labs were crickets. Where did those patients go? They're usually a flurry of activity almost every day. What's happened to those patients? It's going to be real interesting to find that out, because I think we will find it out ultimately. Okay. Here again, the most costly inpatient stays. And what's important about this? Look at 3 through 7 and number 9. Hip replacement, PTCA, cesarean sections, coronary bypass surgery, heart valve procedures, and treatment for fractured hips. Grandmom fell, broke her hip, motor vehicle accident, somebody broke their hip or dislocated, and you have to have surgery. But what that tells me is how much money did the hospitals lose? And knowing how many hospitals there are, knowing how some hospitals are megaplexes, other hospitals aren't quite so big, but there's a lot of hospitals, a lot of surgery centers that may or may not have overnight stays. I'm assuming that the bailout for the hospitals is got to have some criteria, and I don't know if same-day surgery centers qualify the same as somebody that can maybe has 4 beds and can do overnight that's called a hospital. I really don't know. But I do know that the amount of money that they gave is not enough. I don't think these hospitals have been hurt. There's no question about it in my mind. And that's going to hurt all of us. You know, we've talked about this, I've said it several times, I'm a practicing clinician. But I'm in that age group now, and I'm in the at-risk category. I'm in that age for COVID, but I'm in the age group now that I'm going to start needing services. The last thing I need is for the hospitals and the medical teams to be decimated at a time when I'm going to need them. And then, you know, we've gone to these extreme measures. We're shortening medical school. We're saying you're in your 3rd year, you're a doctor. That's it. You know, here you go. Because of this reaction that we had to this issue. Is that the right thing to do? Because those are the people that are going to be taking care of me and you. So are we really doing the right thing here? I'm not so sure. I think that there's a part of me, and I don't want to get into a political discussion, but you know, I'm a business owner. The government is a business. We have to make good decisions. We can't afford, I can't afford to make, big major mistakes. Your company will fall apart. So, a little bit concerned about how this all got handled and how we, the lack of good messaging, as I said, but, without casting aspersions, I think there was a tremendous amount of uncertainty, so I'll accept that. But I do think this has hurt hospitals. I don't think we should be taking people out of medical school and basically giving them a pass on their last year for the sake of flooding the market with a bunch of physicians who may or may not really have what it's going to take care of us when we need the care. I'm just worried about that. I'm not sure I agree with it. I think that needs to be reversed. That's my opinion on that. Okay, so I think perfusion, we need to do certain things. I think first, and it says survey results, that's to remind me to tell you all to do the Slido survey. Please do the Slido survey. Okay, it's important to me. Please do it. And we're going to show you that video as soon as we finish this again. As soon as we finish my talk, while we're getting Dr. Samir linked in. Perfusion needs to demand these things without exception. We need more affordable, simplified ecmo platforms. I am not at all happy with what is currently now available. I don't want a platform that's real big. I don't want a platform that costs so much money that it uses 30% or 20% of the DRG, because it's going to make delivery of ECMO care impossible, or there's going to be, I know a lot of hospitals that do not provide ECMO service. I know a lot of them. They do heart surgery all day long. They do not provide ECMO. That's not because they don't think ECMO is a good tool that really works. They can't afford it. They don't have the staff for it, which gets me to my next point. We need to adopt blended programs with ECMO specialists with exceptional and ongoing training that is founded by perfusion and managed and supervised by perfusion. I think nurses are great people, extremely intelligent, very capable. I've said this a billion times. I'll say it again for the sake of this discussion here today. We're perfusionists and we consider ourselves elite, okay? For whatever reason. But a critical care nurse can be managing a patient on epi, neo, levo, lidocaine, vaso, methylene blue, bleeding, transfusing, fluid resuscitation, fibrillating, pacemaker, ventilator, and on ECMO, and still having to provide human care to the patient, washing them, cleaning, changing their linens, along with managing all of that. And that's just the tip of the iceberg, because they manage a whole lot more than just that. They're in renal failure. Now they got to run CRRT. You just go on down the list. It's a madhouse. And I've seen one nurse manage all of that. I think optimally it should be two, and usually others will help. But I've seen one nurse manage all of that. If you can do that, I can teach you how to be an ECMO specialist. And that is going to, that's basically going to recruit into the Army, into the ranks of those people qualified to monitor an ECMO system that is stable, VV or VA, if they're stable, and provide oversight, continued training, rounds, maybe do the initial insertions until the patient is stable, or manage it if it's unstable, so they can manage the patient, working together as a team. Telemedicine now has become a big deal. And Dr. Samir, who's going to be coming on, happens to be a telemedicine expert, tele-ICU, and he'll be addressing this as time goes on, because this is not going to go away. But we could be doing the same thing. He could be sitting monitoring 4, 6, 10 ECMO patients around the country from a single command center. Him and his team could be doing that. And if there's an issue, he can say, hey, listen, I think you need to call the perfusionist on this. The circuit might need to be changed. Or I think you might need some help with this. Or whatever the situation may be. You know, I like to do recirculation and oxygenate a blood volume using a transonic device. I think I could teach a nurse how to do that too. But if that's what he wanted done, the perfusionist, because it's a blended program, could come in, hook that up, do it, give him the answers that he needs, and that's going to help him assess what he feels the order should be, or recommend to the primary physician taking care of that patient, intensivist or pulmonologist, what might need to be done, or as a suggestion. But you can have a surgeon, you can have a perfusionist doing that, you can have another ECMO specialist doing that. But telemedicine is very easy to do now, and it's only going to get better, because this is a big deal, and it's been needed to be done for a very long time. And it's going to be exciting to see the future as that continues to take hold. We need to adopt, of course, telemonitoring, which I just said, to maximize what are very limited resources, or what is a very limited resource. I was referring to perfusion, but really it's what are limited resources, which happens to be people. You can build all the ECMO pumps you want. You can build all the oxygenators you want. But if you don't have people to manage them that know what they're doing, guess what? It doesn't matter. You can have them. They're not going to be helpful, or not going to be useful, or they're not going to benefit the patient. Just because you put the patient on ECMO doesn't mean that it's going to benefit the patient. You have to know what you're doing, okay? And that takes skill and experience. Okay, I think that is my final slide. So thank you very much. Yeah, that's my final slide.